Okay. Thanks, everyone. Well, that's a tough story to follow, but I'll do my best. Share the passion for taking care of these kids, and thanks so much to the organizers for and Colleen for really a special invitation to be here. So I'm going to talk about leukemia in children with Down syndrome, insights into risk factors and treatment. And I have to apologize, I really don't have anything specific about mosaic Down syndrome because there just really is very little out there specific to leukemia. But I think the basic message is that there is a risk, and the considerations once you're diagnosed with it are the same, whether you have mosaic Down syndrome or regular Down syndrome in terms of how to think about it and manage it. So leukemia in Down syndrome was first reported in 1930 and first systematically studied in 1957. So it's been recognized for a long time that there's an increased risk. There's about a 20-fold increased risk of ALL and about 150-fold increased risk of AML. So that's acute lymphoblastic leukemia and acute myeloid leukemia, which are the most common pediatric leukemias in general. There's a cumulative risk of about 2% of all children with Down syndrome develop leukemia by age 5. So still a very small minority of kids with Down syndrome, but higher than the general population. And I'm sorry that repeated there. So just one interesting fact here that I would be remiss not to mention as an oncologist, but that I'm not really going to talk about more, is that there's this really interesting paradox that there's a much lower risk of solid tumors in children and adults with Down syndrome, so less colon cancer, lung cancer, breast cancer, all of the common adult cancers. There's a markedly decreased risk in addition to this very increased risk of leukemia. And there's some interesting studies on that, but I'm not really going to get into that further here. So even though leukemia has been recognized as having an increased risk for, almost 100 years now, it's still really not fully or well understood, like what is the precise reason or risk. There's a lot of different kind of biological factors that have been speculated about and some good data, but there isn't kind of one smoking gun of this gene on chromosome 21 is exactly what's doing it. Part of it may be an imbalance of a variety of genes that are on chromosome 21 that there's more copies of, so more effect from. Some of it is epigenetic regulation. There are differences in general in development of the blood cell precursors in children with Down syndrome. There are differences in different cellular pathways that are involved in development of cancer, potentially, and there's abnormalities in immune function, and white blood cells are immune cells that impacts development of some white cells. So I'm not going to go really deeper into that, but there's a lot of interesting research going on in that area. So I wanted to focus, first I'm going to give a little overview of the myeloid leukemias associated with Down syndrome, and then acute lymphoblastic leukemia or ALL. So there's two main myeloid leukemias of interest. There's one which is called TAM. It's had a lot of names, TMD or MDS of Down syndrome, but the name that's generally used now is TAM, or transient abnormal myelopoiesis, and then myeloid leukemia of Down syndrome. So TAM is a proliferation of megakaryoblast, which are early precursors that give rise to the platelets in the blood. And it's a kind of really fascinating, kind of unusual form of leukemia, which it looks like leukemia, but it regresses on its own. And it's really uniquely associated with kids with trisomy 21. And in fact, it involves a large number of them, up to 30% if you look by really sensitive methods. But it's really variable in severity. So it can be completely incidental, just noticed as a few abnormal cells on a blood count, or it can be a life-threatening or fatal disease. So, but if it doesn't cause really severe complications, the natural history is for it to go away on its own by 3 months of age. So it's like a leukemia, but really not like a leukemia in terms of not really actually needing treatment to go away. And the clinical course, so it can be fatal because of involvement of the liver or the lungs or the heart. It can cause a lot of really severe complications, but then it does spontaneously resolve in around a month of time to not see the leukemic cells in the blood, and then a couple months to see all the symptoms resolve on average. But again, you can see really wide range of, it can be very brief, just like a week, and then you don't see any signs after that, or it can be all the way out to 3 or 4 months of age before you really see it resolve. And then the other really notable thing about TAM is that there's a much higher risk of the other myeloid leukemia, the MLDS, in children who had TAM diagnosed at birth. So about a quarter of kids who were found to have TAM go on to develop MLDS. Their TAM fully goes away, but then they develop MLS subsequently. And if that does happen, it's always by age 4. Then the last thing about TAM in terms of treatment is that if it does require treatment because of the severity of symptoms, it's very sensitive to very, very low doses of chemotherapy, specifically cytarabine, and that does improve survival by kind of killing off the cells that are there and controlling it until the disease burns itself out on its own. But the interesting thought was maybe that will get rid of those cells so that there won't be a risk of MLDS later, but that's not the case. So it really doesn't change the risk in any way of later developing MLDS, whether or not you give treatment for the TAM. So it's not, has been some studies trying to prevent TAM, and that they haven't been, or to prevent subsequent MLDS, and those haven't been effective. There's a genetic cause that was discovered by John Crispino about 20 years ago now, that there is a single gene really highly associated with both TAM and MLDS, which is a mutation in the gene GATA1, which is involved in megakaryocyte gene regulation, and mutations in this gene have been identified in the leukemia cells, both in MLDS and in TAM. But there's still unanswered questions about how it cooperates with having trisomy 21. What is the role of the fetal microenvironment? Because TAM is observed from early in fetal development to initiate versus the more mature bone marrow environment, and what the timing of events are that cause the progression of the disease and the regression of the disease. But when you have either the leukemic cells of TAM or MLDS present, they all have that GATA1 mutation in them. So this is just kind of a schematic of the relationship between the two disorders, where it's thought that in utero, the combination of trisomy 21, these primitive hematopoietic stem cells, and expansion, then if there's a GATA1 mutation in those cells, that can lead to, this is the GATA1S, the short form of the gene, which causes the expansion of these TAM cells. And that continues after birth and then resolves within a few months. But then those cells are dormant, and if additional mutations occur in some of these other genes, then that can lead to development of evolution into MLDS, this new second kind of true leukemia that requires real myeloid leukemia treatment. So in terms of the MLDS, the unique features of this compared to AML in kids without Down syndrome are that it does occur in a somewhat younger age. It's always under age 4 with a peak of around 1.8 years compared to 7.5 years in other children with AML. It's of this megakaryoblast or platelet origin lineage, and it has GATA1 mutation present. It's much more sensitive to AML chemotherapy than AML in children without Down syndrome, especially cytarabine, and the outcomes are better than in non-Down syndrome AML. Although if relapse occurs, it's much more aggressive at relapse than other forms of AML. So there's been kind of an evolution of treatment strategies for MLDS. For a long time, there was kind of each successive trial would reduce the treatment intensity because of recognizing that the outcomes were really good and that it was possible to reduce the treatment intensity to reduce toxicity while maintaining outcomes, and the outcomes were preserved for quite a while. But the Children's Oncology Group, which is the main cooperative group of over 200 institutions that kind of dictates the treatment followed by most institutions in the United States. The most recent trial omitted the one kind of remaining very intensive block from the treatment, and they unfortunately did see more relapses and had to stop that study early because kids weren't doing as well as they had when that intensive block was kept. So for now, the standard is to use kind of the trial before that as our standard approach. But the goal with future trials is to bring in, there are some newer agents that are being used for AML therapy, and to see if those are as effective for kids with Down syndrome, since we can't get away with just whittling back further and further, that trying some of these new beneficial agents may be helpful. And also to try to refine our risk classification better, to try and not treat all kids with MLDS the same in terms of intensity and approach to their treatment, but to identify some markers to know who needs higher intensity therapy and who lower intensity. Part of that is detecting minimal residual disease after you've given a month of treatment, and the ones who don't respond as well and don't clear their disease need more intensive treatment. And part of it is trying to identify specific other genetic changes that mark kids as high risk or low risk. So just to summarize this part, TAM and MLDS are both really unique forms of AML. There's a lot of insights, but some key questions still about the cell of origin, the role of trisomy 21, what determines resolution of TAM versus progression to MLDS, and then therapeutic strategies to prevent MLDS, ideally from developing, and then how to better treat it, including especially treatment for relapse disease, which is still really a big problem. So now I'm going to move on to ALL associated with Down syndrome. And again, there's similarities and differences from ALL in children without Down syndrome. It affects a pretty similar age range, most commonly the kind of preschool age. The one exception to that is we really almost never see ALL in infants under a year of age, which is not true of children without Down syndrome. And then this particular cell lineage is nearly always B lineage, where the other forms observed in kids without Down syndrome are really exceedingly rare. There's also a distinct spectrum of genetic alterations where the typical genetic subtypes of ALL are not as common in kids with Down syndrome, and there are a couple genetic alterations in the CRLF2 and JAK genes that are much more common. So just showing that on these pie charts. So the left hand is the Down syndrome and right hand is non-Down syndrome. And this is from a big sequencing study that we did, but it's kind of parallels what's been found in general in a lot of studies. And you can see in non-Down syndrome, the pie has a lot of different pieces, and The ETP6-RUNX1 and high hyperdiploid are the most common in non-Down syndrome ALL, and those are much smaller, the green and the brown over here. And then the CRLF2 alterations are over half of Down syndrome ALL, so it's much more common. And again, it's kind of a very obvious and observation, but we don't really understand why this subtype arises so much more often in kids with Down syndrome. So this is just highlighting the different subgroups and how they differ in their frequency. So in terms of outcomes, unlike in AML, where kids with Down syndrome do better, in ALL, kids with Down syndrome do somewhat worse, and that's been true historically and still continues. And it seems to be both due to increased risk of relapse and increased risk of treatment-related mortality. And this is a large retrospective study. The red line is the overall survival, and solid is Down syndrome, and dotted is non-Down syndrome. So it's about over 10% difference where Down syndrome kids have poorer survival. This is the relapse-free or event-free survival, and this is the overall survival, and they're both lower than the corresponding curves. And then this is the risk of relapse, and the green is the risk of treatment-related mortality, and they're both higher for the Down syndrome kids compared to the non-Down syndrome kids. And then we did a study of looking at the last recent children's oncology group trials and found similarly that the event-free survival was poorer and the overall survival was poorer. And so that's true in more recent years as well as the older Ponte de Leño study. And then again, also for risk of relapse and risk of treatment-related mortality in the COG studies was also higher in Down syndrome kids. This is showing some of the toxicities of chemotherapy, both in standard risk and high risk ALL. And standard risk patients don't get as intensive therapy, so the rates aren't as high as for the high risk, but in all cases, the Down syndrome are in red and have higher rates of mucositis or mouth sores, much higher rates of infection, higher rates of hyperglycemia or high blood sugar. And then we also saw higher rates of seizures in the high-risk kids. So primarily that's kids over 10. So the older they are, the more risk of having seizures during treatment. And the infection risk is really of the greatest concern because that is responsible for the differences in survival related to treatment-related toxicity that I was showing earlier. It's really because of life-threatening or fatal infections. And this was observed starting in the early 2000s, both in the COG and the UK trials. And it was kind of a pattern of during periods where the blood counts are very low, and we do see mortality in non-Down syndrome kids also, but the rates are just much higher in kids with Down syndrome. And there was a series of safety amendments to somewhat reduce the chemotherapy intensity and greatly enhance supportive care and try to manage infections much more aggressively. And that did improve things somewhat, but we still see a higher rate despite all of those efforts in kids with Down syndrome, unfortunately. So it's still an area we're really working on. And it's not any one particular type of infection. It's really across the board, different bacteria, fungi, and viruses. And it does increase in risk with age. So older kids are of higher risk. And then another new agent that we've started using called blinatumomab, I'm going to talk a little more about soon, but part of the risk of seizures that we've seen has been specific to this drug. It is a known risk of using this drug, but the frequency is higher in kids with Down syndrome. And as I mentioned, especially in kids who are over 10 years old. Most of the seizures occur early during the first few days. And so far, it's pretty new that we've started using this drug. So this is just preliminary data on this, but in the cases so far, it's just being given as part of this study, and the cases reported fully resolved. 5 out of the 8 patients were given the drug again, a lower dose, and didn't have recurrent seizures, although there have been a couple reports since then of seizures recurring and needing to stop the drug altogether. And now the study is mandated to use anti-seizure prophylaxis, anticonvulsant medication during the blinatumomab infusions, and we're hoping that that will enable using this really effective drug without having the seizures come up. Then late effects is an important area of research because survival really is so greatly improved in recent years for ALL. So it's really important to us to look at how children do long term and what any late complications of therapy. And there's unfortunately really few studies of this in kids with Down syndrome because, as has been mentioned from some of the other talks, they get excluded from these studies because they have a different baseline. And so it muddies things to try, at least in the viewpoint of past studies, to include them in this research. But there have been a couple studies, one that looked at survivors with Down syndrome compared to matched individuals with Down syndrome without leukemia, and did find increased risk of a number of health conditions, including cataracts, hearing loss, and thyroid cancer. And then another study looked at rates of death and hospitalization among survivors. And they found in that case that it didn't seem to be late effects of therapy that were causing problems. It was just the patients that relapsed that had more problems with survival or hospitalizations. And then finally, there's been one small study to date looking at neurocognitive late effects, and it did suggest impairment in a number of domains, but it was really a very small study. And I'll talk about some future studies that we're hoping to get more data in this area. So really our current approach to treatment in Down syndrome ALL is to modify chemotherapy a little bit in terms of some of the very immunosuppressive therapy that has the most risk of infection, and especially methotrexate, which kids with Down syndrome are especially sensitive to, and using kind of a rescue medicine more frequently that helps block methotrexate effect. And then really enhancing the supportive care of keeping under observation in the hospital during intensive cycles, and using preventive antibiotics and antifungals, and following immunoglobulin levels. And it's really a tightrope of trying to avoid excessive toxicity while still having efficacy and adequately treating the leukemia and preventing relapse. So there are some really exciting new strategies that have potential. One main one that's really changing our treatment of ALL in general is immunotherapy, either to replace intentional chemotherapy or at least integrate into chemotherapy regimens. And it has both benefits of reducing toxicity because these drugs or these treatments are generally better tolerated, and having really effective anti-leukemic impact. And then there's also some targeted therapies that you've heard some about JAK inhibitors, and these pathways are also upregulated in Down syndrome ALL, and that may be another area for using these drugs, although there really isn't efficacy data yet. There was one trial that Down syndrome kids were excluded from, but if it shows that this drug is effective, then it may be something we could use for Down syndrome kids in the future as well, because so many of them have the JAK and CRLF2 mutations in their ALL, and then some other genes where there's potential for targeted therapy in the future. So How are we doing for time? Okay, so I maybe won't go into the immunotherapy too much. This is just such exciting, cool new treatments. They're not Down syndrome specific, but I think they have a special potential benefit in this population because of their vulnerability to toxicity. So I'm not going to go into the details of how they work, but they're basically drugs that kind of harness the body's immune system to attack the leukemia, rather than just drugs that kill cells, and both normal and cancer cells, and have more side effects to them. So there's a couple exciting new drugs, and then there's also CAR T cells, which you may have heard about, that where cells are taken from the body, genetically modified so that they'll recognize the leukemia, and then reinfused, and they expand and attack the leukemia and persist on a long-term basis, in some cases for decades. And so it's a really exciting form of therapy. And there's really some encouraging data from some small reports in kids with Down syndrome that these drugs are in general well tolerated and have a similar profile of safety and efficacy as in kids without Down syndrome. So they seem like an area of real promise. So there's really a need for innovative approaches to trial design to try to include kids with Down syndrome in more trials of new agents, give them safely, but give access to these drugs for these patients. So just to summarize, there's a real spectrum of genetic subtypes in Down syndrome ALL that's distinct from non-Down syndrome. Poor outcomes due to both relapse and infectious toxicity, and some areas of real need are access to novel agents, identifying risk factors, improving our preventive and supportive care, and then more studies of neurocognitive outcomes and late effects. And then I had a section on some of our ongoing studies in progress. I'll skip that for now, but thanks everybody, and I can take questions later.
How will you need to have two children with Down syndrome? I think I'm the only one. I think I'm the only one. So with my first child, with respect to, because this is obviously a scare as a new parent, everybody I know with a child with Down syndrome is deathly afraid of leukemia. So with my first child, I think I just held my breath, and that was my solution. I mean, is there anything as a new parent? That's what I'm doing. That's my strategy with my second child too. She turns 5, I'll breathe again. But I mean, is there anything that we should be thinking about with respect to this? Like, how do we interpret this, like, from a layman standpoint?
Yeah, that's a great question. I mean, I think knowing that it's 2%, I mean, that's a small number. So I think, for an individual parent, you can take comfort in the fact that it's not a super likely thing. But I think, as the story from Dr. Mobley illustrated, just like, making sure that things don't get ignored or overlooked if there are concerns. I think as an oncologist, I see lots of kids with and without Down syndrome whose symptoms kind of percolate for quite a while before they finally come to attention. And that, so just being aware, like, if something seems not right, to trust that and keep asking and seeking evaluation. And with leukemia, it's really like, recurrent fevers with no reason for it that just keep coming back, or being really pale, unusually pale, or increased bruising or bleeding, or swollen lymph nodes. So seeing those kinds of things, just asking questions and getting a blood count, and getting a lot of times, like, if a pediatrician just like says, oh, it's a infection, give antibiotics and send out the door, but if you do blood work, a lot of times you see abnormalities that you won't see or know if you don't look in the blood. Yeah.
Speaking of blood work, would the annual blood workup every year at the pediatrician show the signs of potential?
So not 100%. So you don't always see it in the blood. You can have, bone marrow disease and not see it in the blood. And also it can go from not detectable to detectable much quicker than an annual blood test is going to pick up. So the odds that it could happen in the time between tests is there, but so I wouldn't really rely on once a year blood test as useful. It's more just being responsive to symptoms if you have concerns and talking about them with your pediatrician.